Clinical decision making introduction. A great deal of knowledge and skill is required to practice as a doctor. Physicians in the 21st century need to have a comprehensive knowledge of basic and clinical sciences, have good communication skills, be able to perform procedures, work effectively in a team, and demonstrate professional and ethical behavior. But how doctors think, reason, and make decisions is arguably their most critical skill. Knowledge is necessary but not sufficient on its own for good performance and safe care. This chapter describes the principles of clinical decision making, also known as clinical reasoning. The problem of diagnostic error. It is estimated that diagnosis is wrong 10 to 15% of the time in specialties such as emergency medicine, internal medicine, and general practice. Diagnostic error is associated with greater morbidity than other types of medical error, and the majority is considered to be preventable. For every diagnostic error, there are usually several root causes. Studies identify three main categories shown in box 1.1. However, human cognitive error appears to play a significant role in the majority of diagnostic errors. Human cognitive error occurs when the clinician has all the information necessary to make the diagnosis, but then makes the wrong diagnosis. Why does this happen? Three main reasons have been identified: knowledge gaps, misinterpretation of diagnostic tests, cognitive biases. Examples of errors in these three categories are shown in box 1.2. Clearly, clinical knowledge is required for sound clinical reasoning, and an incomplete knowledge base or inadequate experience can lead to diagnostic error. However, this chapter will focus on some other aspects of knowledge that are important for effective clinical reasoning, including use and interpretation of diagnostic tests, cognitive biases, and human factors. Clinical reasoning definitions. Clinical reasoning describes the thinking and decision making processes associated with clinical practice. Our understanding of clinical reasoning derives from the fields of education, cognitive psychology, studies of expertise, and the diagnostic error and health system literature. Clinical reasoning can be conceptualized as a process with different components, each requiring specific knowledge, skills, and behaviors. 1.1 Root causes of diagnostic error in studies. No fault. Examples: unusual presentation of a disease, missing information. System error: inadequate diagnostic support, results not available, error prone processes, poor supervision of inexperienced staff, poor team communication. Human cognitive error: inadequate data gathering, errors in reasoning. Box 1.2 Reasons for errors in clinical reasoning. Knowledge gaps. Examples: telling a patient she cannot have biliary colic because she has had her gallbladder removed. Gallstones can form in the bile ducts in a patients who have had a cholecystectomy. Misinterpretation of diagnostic test. Deciding a patient has not had a stroke because his brain scan is normal. Computed tomography and even magnetic resonance imaging, especially when performed early, may not identify an infarct. Cognitive biases. Accepting a diagnosis handed over to you without question. The framing effect. Instead of asking yourself, what is the evidence that supports this diagnosis? The UK clinical reasoning in the medical education group. See further information broadly list these components as history and physical examination, use and interpretation of diagnostic tests, problem identification and management, shared decision making. Not all of these components are necessary for effective clinical reasoning, and they do not necessarily happen in this order. They also occur in the context that impact on decision making, which will be explored later. Underpinning all of this is formal and experiential knowledge of basic sciences and clinical medicine. The knowledge required for effective clinical reasoning includes factual knowledge but also conceptual knowledge, how things fit together, as well as procedural knowledge, how to do something, what techniques to use, plus an awareness of and an ability to think about one's own thinking, also known as metacognitive knowledge. This is where an understanding of cognitive biases and human factors is important. Figure 1.1 shows the key concept components involved in clinical reasoning that will be this explored further in this chapter. History and physical examination. Even with major advances in medical technology, the history remains the most important part of the clinical decision making process. Studies show that physicians make a diagnosis in 70 to 90% of cases from the history alone. It is important to remember that the history is explored not only with the patient but also and with consent if required from all available sources if necessary. For example, paramedic and emergency department notes, eyewitnesses, relatives, and or carers. However, clinicians need to be aware of the diagnostic usefulness of clinical features in the history and physical examination. For example, students are often taught that meningitis classically presents with the following features: headache, fever, meningism, photophobia, neck stiffness, and other signs of meningeal irritation such as Carnick's and Brudzinski's signs. However, knowing the frequency with which patients present with certain features and the diagnostic weight of each feature are important in clinical decision making. Many patients with meningitis do not